Okay, so with everyone's permission, I'm starting with today's session now. Greetings and a warm welcome to all the interns present here. I'm Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for the doctors. Clearnet is selected to be chosen as a digital partner for this event organized by National Neonatology Forum, Gujarat. So today's focus would be POCUS, a Series 28 live demo of the normal LUS views and common pathologies. So without any much further delay, I would like to hand over the session to Dr. Kunal sir. Over to you, sir.
Yeah, good afternoon, everyone. So today we are continuing with our neonatal Pathshala series, and we have the focus series today. That is the series number 28, and we will be seeing for the live demos of the lung ultrasound. Thank you so much, Mohit sir, for joining with us and continuing it for so long. So you have continued with us for 28 weeks. So thank you so much, sir. It is a pleasure. It is always a delight hearing from you and learning from you. And the live demo session is the most awaited one, and all are very excited to see the practical aspects of it. So thank you so much, sir, for joining with us. Now I will request Dr. Vishal Goyal to start with the further proceedings.
Thank you so much, Kunal. And as the Dr. Kunal already said, that it is a pleasure to hear the from the Dr. Mohit sir. I think he does not need any introduction. He is one of the pioneer of the focus in neurology in India. But at a formal introduction, he is the director of the Neonatal Functional Eco Academic Surat. He is a consultant neonatologist, cardiologist at Surat Kids Hospital, Surat, national convener for the Neonatal Eco Workshop, editor-in-chief and Journal of Neonatology, NNF India, and he is one of the first neonatal cardiologists, PhD explorer in the India. He trained under one of the international pioneer doctors like Dr. Martin and Dr. Patrick. And I think a number of, I think multiple time he conducted a workshop and he's doing a great work in the focus area. So thank you so much, sir, to accepting our invitation and join over here. And over to you, sir.
Thank you, Dr. Kunal, Dr. Vishal, and thanks, Gujarat and NF. And the thing is, once the things get settled and everybody goes in favor of that, so this neonatal Pathshala is one of the example for that. I'm really thankful to everyone. They have been contributing it because this thing we started on a very small scale when I was Gujarat NNF president and it was COVID time. Since then, it has flourished and it has increased and make bounds. So I'm really thankful to everyone for contributing into this and for the introduction. And today, what we will do is we have already in the last session we have discussed the normal lung ultrasound findings, what we see in the normal lung, and then in various pathologies like pneumonias, RDS, TTN, and all. So in the unit, pneumothorax I will not be able to demonstrate, but we have preterm babies, so the RDS in the scoring and the normal findings of the lung. So we will be discussing. So that I will do the demonstration. So this is for everyone. I don't know if this they can do that or the Clarinet can do. When I do, because I will be showing on my mobile. So this is the device from which I have logged in. If you can pin my video into that, so that it remains in the center of the device on which it is getting recorded and on everyone's device. So if somebody can pin my video, so that will be helpful for everyone. So now I will go into the unit and we'll start with the live demo. So just wait for a minute and I will start. So hello everyone. So I'm now in the unit. So first we'll start with the normal baby, and we will start with the normal uh, views of the lung ultrasound. उसको उधर करना उधर पीछे किसका. So first, okay, which probe we use to use the lung ultrasound. So we can use the phase array probe or sectoral probe, but the best probe to do the lung ultrasound is your linear array probe. In newborns, the linear array probe is this. This is hockey stick probe, but you do have the normal linear array probes also that is used in pediatric and adults. So we have this hockey stick probe. In this, there is no probe marker as such. The free end is the probe marker, this one. So before using on the baby, you should be thoroughly cleaning the probe. That is very important. What we do is we normally use the non-alcoholic wipes that we use for the babies. We use to clean the probe with that. So all the aseptic precautions has to be taken. And now when you will attach the probe, this screen you will get. So as you can see, this is a preset for me. There's a lung ultrasound. And the probe orientation marker as it is radiology will always come on the right side of the screen. And this is your probe foot here. The depth we normally keep in the lung ultrasound is 2.5 to 3.5 centimeters. So my default setting which I have kept is 3 centimeters. Sister, beta lines. Okay, so these are the things, and then here I have the options. So you can set it in the 3 parameters. P is penetration, G is journal, and R is resolution. As we need to see the in-depth structures also, so by default we always keep the option of penetration. That means the normal frequency of this probe is 15 till 15 hertz. Okay, it is 10 to 15 hertz. Mine is 7 to 15 hertz. So it goes on the upper side of the frequency, that is towards 12 to 15 hertz frequency. So that's why, and if it is resolution, if it is journal, it will remain in the range of 10. And if we take penetration, it will go in the range of 8 to 10. So means it takes the lower side of frequency so that we can have a better penetration. But rest, we can decide that where the knob is to be set when we put the probe on the baby's chest. So that is regarding your probe and the settings on the machine. Now let me first show you, that is the regions or zones that we have already discussed with you in the previous sessions, that there is a 12 region approach and there is a 6 region approach. So the 12 region approach and the 6 region approach, how we divide the regions, I will just show you on the baby. So we do have Dr. Ashwini with us. He is one of our 6th batch candidate for 6 months courses. So he is there for the hands-on training at our unit. So in this baby, so this is your sternum. This is your sternum. So from the lateral, like from the sternal line, this I'm doing on the left side of the baby. To the anterior axillary line is anterior zone. Anterior axillary line to posterior axillary line is lateral zone. And from the posterior axillary line, side to this scapular line is posterior zone. So these are the 3 zones, three regions on the left side. Similarly, you have the 3 regions on the right side. So this is known as the 6th region approach. 6th region approach. And if we draw a horizontal line, that is at the line of the nipple, these 2 nipple lines, and extended backwards till it goes and joins the scapular tip. So that is, you divide these zones in upper and lower. So this is right upper, right lower anterior, left upper, left lower anterior. Then you have left upper and left lower lateral. And then you will have left upper and left lower posterior. So that is 6 regions, 6 zones on the left side and 6 zones and 6 regions on the right side. To make it easy to speak and remember, so we label it as R1, R2, right upper anterior R1, right lower anterior R2, similarly R3, R4. That is right upper lateral R3, right lower lateral R4, and backwards if we do R5 and R6, right upper posterior R5, right lower posterior is R6. Similarly, we have L1, L2, L3, L4, L5 and L6 posteriorly. Then we have the then we do it, then we do across the diaphragm. So that point, that is a trans diaphragm ultrasound we keep to the probe. But one point that is very important in that is a flap point that is on the side of the liver, that is on the right side. So this is, you can see, is the anterior axillary line, posterior axillary line. So this is a point where there is a posterior axillary line. So lateral lobe and the posterior lobe, this is the border. And then at the level, posterior lower one, where there will be liver in the lower or side. Liver here and lungs above. I will show. This is known as the flap point. This is very important to look for the diaphragm and even for doing the pleural effusion. If there is a pleural effusion, the fluid will be collected in this particular region more. First, you will see in here. So this is regarding the regions, 6 region approach and 12 region approach. And then we have the RDS scoring. For RDS scoring, we don't use these zones. For RDS scoring, that commonly what we follow is again a 6 region, but the zones are R1, R2, and R lateral as single. L1, L2, and L left lateral single. So these are 3 regions on the right, 3 regions on the left. This is what we do for the RDS scoring. We don't take the posterior zones because they are the dependent zones, and scoring, as you must have gone through in the previous sessions. So in that, the scoring will be falsely high. So these are the 6 regions that we use for the RDS scoring. Okay. Regarding the placement of the probes, so probe, one approach is to keep this probe foot pointer towards the head, and that probe foot is perpendicular to the intercostal spaces or the ribs. It is perpendicular. So this is your longitudinal approach. Then you have a transverse approach in which the probe foot is being kept in the within your intercostal spaces. So when you are doing advanced studies, then the both you have to take the images on both. But for our regular clinical practice and assessments, we just follow this approach. That is, the foot is being kept perpendicular to the ribs or the intercostal spaces like this. So we will show all the views by keeping the probe in this position only. And your probe should be perpendicular to the skin surface. It should not be moving or angulated much. It should be, most of the time, it should be perpendicular. So that's how you keep the probe on the baby's chest. The gel should be preheated, either it should be preheated, or what we do is, in our unit, this is what we follow normally. We put it in this pipe and then keep it for some time. We keep it under this heater. So this is how we pre-mount the gel. Ideally, there should be a water bath in which you will keep the hot water bath. You will keep this gel bottle. धीरे बोल बेटा. धीरे बोल. So then you can keep it in the baby's warmer only. Now I will be showing the normal views. So I'm keeping my probe in L1 area, okay, left anterior zone. So here you start seeing it. So I have to optimize the image. So what I've done is I press the eye scan. There is auto gain adjustment. And now you will see this heart, it is pumping. So that is what you will do, that what happens in the left side. So that's why to rectify this, what you need to do, you go lateral. So now I have become more lateral on the baby's chest to see the lungs. On medial side, there will be a heart. So this is what you see, subcostal. This is skin, subcostal tissue, subcutaneous tissue. This is the muscle. In between those two hyperechoic, do you see hypoechoic? This is muscle. These are the ribs, the black holes. And then below the holes, below the rib, you will be a caustic shadow will be there. In between the two ribs, you have this hyperechoic line, which is, you can see moving like this. This is your pleura. And the movement of these lines, the way they are moving is known as the lung sliding. In this hyperechoic horizontal lines, if you see, the horizontal lines are the A lines. The theory has been discussed with you. And then you see these vertical lines, hyperechoic vertical lines, which are starting from the pleura and ending till the end of the sector. Okay. And they are moving along with the movement of this pleura. So these hyperechoic lines, which are moving with the pleura, and they are starting from the pleura and going down till the end of the sector, they are the B lines. So these are the B lines, horizontal one are the A lines. So in between the two ribs is one sector. This is one sector. In one sector, in some of the lines, see, you see these lines coming from, starting from the pleura ending in, till the end. But there are some lines, vertical hyperechoic lines, when they where they start from the pleura and they end before reaching the end of the sector. You see this. It's starting from the pleura and is ending here. So these are known as the comatale artifacts. Then we calculate the B lines in one sector. If there are three and less than three B lines in one sector, they are known as simple B lines. 1, 2, 3, 4. Here I can see 4 B lines. If there are three more than 4 B lines in one sector, it is known as the confluent B lines. And in these two sectors, you can see there are more than 3 B lines. So they are confluent B lines in two consecutive sectors. So if they are there in 3 sectors, I am moving the probe down. If 3 consecutive sectors have got confluent B lines, then they are known as AIS. Okay. So what you are seeing is skin, subcutaneous tissue, pectoralis muscle, two ribs, intercostal muscles. In between the two ribs, you have the lung tissue, hyperechoic line, which is moving like horizontally. So that is known as the lung sliding or pleural sliding. And then you see horizontal hyperechoic lines, there are A lines, and vertical hyperechoic lines are the B lines. So this baby is of HI stage 2. Baby was on some oxygen and this thing. So still the lungs are wet. They are not having cleared off. So in this, in the normal lungs, if there is no pneumothorax and there is a lung sliding going on, we can do the M mode. M mode button. And here you can see I brought this cursor in between these two ribs. This is the lung pleural line. And this is the M mode finding you will see. And this is what we call as the sandy beach sign or seashore sign. So this is your subcutaneous tissues and muscles. This is pleura and this is your lung tissue. So this is known as sandy beach sign or seashore sign. So that is regarding the normal lungs. In the normal lungs, I've told you the regions where we how the lung chest, baby's chest is divided in various regions. Then I showed you the regions for RDS scoring. Then I showed you A lines, I showed you the lung sliding, how the normal structures they look like in the normal lung ultrasound, how to keep the probe, where to keep the probe. And then I showed you the B lines, what are simple B lines, what are confluent B lines, confluent lines, and then what are AIS, alveolar interstitial syndrome. And when the vertical hyperechoic lines, when they start from the pleura and they don't reach till the end of the sector and disappear before that, so that is what we call as the comet-tail artifacts. So this is what I showed you. Now I will show you these findings in this baby on the right side, and then how we keep the probe on the flap point and what are the things we see on the flap point, I will show you. Clear? If you have any questions, you can ask. It will be helpful for people who are attending online. So now I am putting the probe on the right side of the baby. So here again you see subcutaneous tissue, muscle, intercostal space, pleural sliding, lung sliding, A lines and B lines, same. So the intensity of the B lines, when we'll discuss RDS, I will show you on the baby with RDS who was intubated, given surfactant, now has been extubated on NIV, 1.1, 1.2 kg baby. I will show the findings in there also. So I will show how to keep the probe on the flap point. थोड़ा इसको ना लेटरल करना पड़ेगा हाथ 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 साफ करना इसको So this is where you keep the probe in the flap point. In here you see, this is liver, these are lung, this is pleura, B lines, lung sliding is happening, and then you have this liver. This is liver constituency, this is lung, and then if you see this, these two hyperechoic lines, and there is a hypoechoic area in between. So this is your diaphragm. So when we can calculate the thickness of the diaphragm, so it is around 2.13 millimeters. 2.1 millimeters. So that's how there is a lot of significance in the with this diaphragmatic thickness and excursion, inspiration, excursion, insertion, expiration, excursion. That ratios are there. So, but these all things are be covered in the advanced courses of the lung ultrasound. So, but this is a point where you can see even the diaphragmatic movements, diaphragm, and the pleural effusion. That is what is we call as the flap point. Now I will move on to babies with the who are premature with NIV was given surfactant, and we will see do the scoring of RDS in that. उस पे लगा दे मशीन तो सर बेटा इसको बच्चे को साफ कर देना ये 2 नंबर वाला था So this is the baby preterm on NIV. So we'll do the lung ultrasounds in this. Your environment surrounding should be well adjusted. So that's why the light should be dim. There should be no bright lights. Otherwise, they will shine on your machine screen, and the brightness and the gain of the images that you will take will be affected. So again, you can see I've cleaned the probe. I've taken a new wipes. I put a gel on the wipe. I'm heating the gel before starting my ultrasound study. So that is very important. You should take care of your surroundings, environment, and proper asepsis. Otherwise, you can spread sepsis in doing focus only. बेटा इसका बिल्कुल क्या होती है So I will be doing the RDS scoring. So this is L1, L2, R1, R2. This is left lateral, and this will be right lateral. So we'll do the scoring. The score is 0, 1, 2, 3. The maximum scoring in all the 6 regions will be 18. And any scoring which is more than 9 is an indication to give the surfactant. So this one I'm doing in L1. So here you can see there is a confluent B line here, confluent B line here, and confluent B line here. So 3 sectors with a confluent B line is AIS. And if you have AIS, that means the score is 2. In the sub-pleural consolidation is there, or there is a compact B lines. In compact B lines, you will not be able to differentiate the lung tissue from the pleura. It will be all white. Then it is compact B line, then the scores are 3. So L1 score is 2. Now I'm putting the probe in L2. Again, you see in L2, so you are seeing this 3 sectors. Again, you have confluent B lines. So it is AIS. So score is 2. Now I'm going to left lateral. In left lateral, there is a very interesting finding. Here you see, these are the lobes which are towards the head. These are the lobes which are towards the foot. Upper ones, you see there are much lesser B lines and A lines are there, but the lower ones are having the B lines. So this is typical finding of TTN. In TTN, you have this finding, what we call as the double lung point. And this is what you see in the resolving RDS also. If you have a severe or moderate to severe RDS and it is resolving, then the upper lobes see more aerated. You see very good A lines and very 1 or 2 B lines only. But in the lower lobe, you see the confluent B lines. So this is your double lung point. So you see double lung point in 2 common pathologies. One in TTN, which is diagnostic of TTN, and other one is the resolving RDS. So this sign tells me this is a resolving RDS. So if I take this, if you see A lines, it is score 0. And if you see confluent B lines, score 2. So if I take it as 1, so on the left side, you have a score of 5. So now I'm going to do the scoring on the R1, that is right side. Just now, 2 hours back only we extubated this baby. So again in R1, you see AIS. And no, there is subpleural consolidation also in this. It is all white. So this is score 3. R1. R2, again, you can see thickened pleura, how thick it is, and there is subpleural consolidation. You cannot make a thin straight line of pleura, it is all thickened. So this is subpleural consolidation, or we also call it as there is thickened, very thick, irregular type of pleura you can see, which is moving. So it is all 336. And then this is right lateral. And right lateral also it is confluent G lines. So on the right side, the score you can see is 33628. And on the left side, it is 5. So total score is 13. This is again an indication of surfactant, but we have already given this baby surfactant and now it's been extubated just few hours back. So FID requirement is around 30%. Fine. So then you can say this can be the RDS which has gone, which was sphere. Now the scoring must have increased. So that's qualify the baby for the second dose of surfactant. Okay, in the previous baby, you saw the B lines which were less in number. Okay, in this, in almost all the regions, you see the confluent B lines. On the right side, you saw the compact B lines. And on the left lateral lobe, you saw the double lung point. So this is some very interesting findings. Why it is so? Because the actual findings have been modified, which was sphere. We gave surfactant and extubated this baby. So this may be the RDS which is resolving, or it may happen that if it does not resolve, it remains like that. If we do the lung ultrasound after 2 to 3 hours, then this baby qualifies for the second dose of surfactant. So that is how you do the scoring. This is known as the Brad scoring. So these 6 regions which I've shown you are the commonly used scoring for the lung RDS in the lung ultrasound is the Brad scoring. And this is what we did in this baby. So that is the scoring. B lines, confluent B lines, AIS, compact B lines, double lung point, normal B lines, that is simple B lines, A lines, lung sliding, seashore sign that we have seen in today's live demo, and how to divide for the regions and zones, and how to keep the probe, where to keep the probe, what is the plap point, what are things we see in the plap point, how the diaphragm look like, all those things we have seen in this live demo. So now if you have any questions or any doubt, you can please put it in the chat box so that we can see the questions and we can try to answer. And I will also ask Dr. Ashmi if he has got any doubts. It's very well explained. I don't think so. I have baby with pneumonia. You can write down the questions. I will just looking in the unit. If I have any baby with pneumonia, then I can show you the shred sign. Sorry, all the babies with pneumonia, everything, either they have been discharged horizontal or they have been discharged vertical. So that's why we have only preterms, TTN, RDS, or feeder and growers in the unit for the time being. है कुछ? So is there anything on the chat?
There's a one question in the chat, sir. What is the thickened pleura?
So thickened pleura, let me show you in this baby. I showed you the pleura in the other baby. I will show you the comparison in both the sides. So you see this on the left side.
We could not see, sir. Videos are on. Sir,
अभी on
video
है,
is
दिख
off,
नहीं
sir.
रहा? दिख रहा है?
The video is off, sir. Can you start the video, sir?
अभी आया?
Yes, we can see, sir.
Yeah. Now you see this. In this, you can see this pleura which is moving, which is very defined. Very well clearly defined here. Okay, किसका बज रहा है? बंद करो यार ये. तो फिर ठीक करो उसको फटाफट. So this pleural thickness is 0.4, 0.5 millimeters. This one. This is on the left side where we saw the double lung point. Now I will show you where the pleura was thickened and the scores was high on the right side. Now you see this. There, very clearly you were able to see a well-defined hyperechoic line. But here you see the pleura is merging with the lung tissue. You cannot see any well-defined hyperechoic line. So we even cannot measure the size of the pleura. And if I make an idea that this is bit higher hyperechoic, if I go there and measure the size, it is around 2.6 millimeters. The normal thickness of the pleura is 0.5 to 0.8 millimeters, 0.5 to 0.8. So in this one, it is totally ill-defined, cannot be measured. And if I try to measure also, the rough value is coming around 2.6, 2.7 millimeters. So this is what we call as the thickened pleura. Thickened pleura is a feature in pneumonias, in severe RDS. So in and in if you have pulmonary edema and all, where the lung tissue is very wet and it cannot, it is like a compact B lines. So there also the pleura is thickened. So this is what we call as a thickened pleura.
Sir, there's a one more question that how does score one looks in the RDS, sir?
So score one is just simple B lines. That means in one sector, 3 or less B lines. Like this one, I show you in this baby in the lateral ones, where we upper zones, you have like these zones. There are only 1 or 2 B lines. Here there are more than 3 B lines. They are confluent B lines. Here you see A lines, only 1 or 2 B lines, simple B lines. If you see only A lines, then it is 0. If you have a simple B lines or only confluent B lines, it is score 1. But if you have AIS, then it is score 2. That means confluent B lines in 3 or more sectors.
There's a one more special BPD pattern, but I think it is difficult to demonstrate because we need some
Sorry, क्या
consolidation and
बोला?
everything.
I,
So BPD pattern, so it is difficult to demonstrate in that patient. Am I right, sir? The
yeah, we
pleura
don't
is
have all the babies,
uh,
BPD babies have been discharged.
yeah.
These are all fresh babies here today. So we don't have a BPD babies here, but the pattern is very irregular. There you can have a thickened pleura or you will have confluent B lines. So like that. So
Consolidation.
BPD pattern is very irregular.
There's one more question: how to differentiate from the RDS, but from BPD or something like TTN? They haven't
Pardon, what?
clarified.
You
How
want
to
to clarify?
differentiate from the RDS, but for from what actually?
So
How to
RDS is
differentiate
more
from?
of a homogeneous disease. So you will
Mm.
get the patterns in different zones. Okay, this homogeneously you will get this, but BPD is totally inhomogeneous. Okay, in some areas you may have only A lines present. There won't be any B lines. Some areas you will have a confluent B lines, or if there is a consolidation, the collapse is there, or consolidation is there, you will be having the irregular pleura there. So it is inhomogeneous. RDS is homogeneous, irregular pattern. In one patch, you will have one kind of finding, in other, you will have different. In RDS, it is more of a homogeneous disease. then you will have thickened pleuras in RDS, severe RDS. In BPD, you won't have the thickened pleuras. And then if it is pleura is thick and severe RDS, you will have a pleural movement can be absent in that. But in BPD, whatever may be the thing, your pleural lung sliding will be maintained.
And there's another question: how to differentiate from meconium?
Differentiate?
From the meconium aspirate syndrome,
Meconium
MAS.
aspiration syndrome and
Hmm.
how to diagnose MAS, is it?
Yes, yes, yes.
So in MAS, we have this again consolidation, and then we have a spared areas. That, like I showed you, in the upper zones, there are normal A lines and lower zones are B lines. In spared area means middle zone will be A lines and a zone above and below will have confluent B lines. So that what we call as spared areas. So spared areas is diagnostic of MAS.
I think everything is fine. So now you solved all the queries from the delegates, sir. So there is no more question from there.
Then okay, then I will leave from the unit. I will go inside, and then we can. If
Find out the
everything
things.
is fine, is okay, then we can even close the session. Over to you, Dr.
Okay.
Vishal and Dr. Kunal.
Yeah. Thank you so much, sir. I think it was a fantastic live session,
Okay.
and you really nice demonstrate all the A line, B lines, and thickened pleura. Of course, because of the patient is not there is no pneumonia patients, it is difficult to demonstrate the pneumonia on that baby, and very much into the scoring system. So thank you so much for that. Kunal, do you have anything, Kunal? I think Kunal is not there. So overall, I think sir will be, give insight once he reach to the office.
So yeah, I think so. This then only few sessions in the POCUS is being left, and we will be doing that. Lung pathologies and live demos. We have done the lung ultrasound. So the only thing is left is the lines and all. So that session we will take, and then it will finish the POCUS series completely.
Sure, sir. There's a one more question, sir. Differentiation between the P and E. I think emphysema. I think they are from the BPD.
Yeah. So see, there is a lot of other pathologies, but as this
Yeah.
is we have kept as a basics one, so that's why we have not included the complicated thing. But like there we do run 3-month courses are there. So we do all these pathologies and this thing. It is for in the basic workshops, especially, it's difficult to cover these pathologies. There is a lot of difference because I have not even discussed the profiles. There are different profiles, what we call as A profile, B is prime, A prime B, A B prime. All those things are there. There is a lot of the lung ultrasound is a very big topic, but we have only discussed and taken in the Parshala, we discuss only basic things. So yes, emphysema, emphysema will be, you will have more A lines, but the difference between emphysema and your pneumothorax is that in emphysema, your lung sliding is maintained. So because the simple differentiating point is M mode, when you do M mode in pneumothorax where your lung sliding is absent, then you will have stratosphere sign or barcode sign. But in emphysema, your lung sliding will be maintained and you will have more of A lines because of air. But when you do M mode, it will be your C short sign. There is a basic difference how you can differentiate.
I think there's no more question from the delegates. I think it was very nice session, sir. And I think every time when you do the lung ultrasound, even in your unit, you learn the new thing. It is not like the curriculum for the lung ultrasound. Of course, there is a background, but every time you will get new and new things. So if you apply in the routine practice, I think it would be more beneficial.
Okay, then can we finish then? Close the session?
Yeah, sir. Sir, we can close the session. I think, Swastika, we can end the session. And thank you so much, sir. It was really appreciate did, and I think live demonstration is a like is a beautiful thing. We can see that what we learn previous session and now we how can we see in that one, so we can connect together and easily we can apply in the NSU. So thank you so much, sir. Swastika, you can end the session now.
So
Swastika.
thank you so yes. So thank you so much to all the dignitaries who have present here. Client is really glad to have all these brilliant people together in the session today. And I really hope that you all had a seamless experience. So with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much.
Thank you, sir. Thank you, Mohit, sir. See you.